Don't tell Steinberg that last patient was dead. Don't tell him. Anyway, just a couple of things, couple extra things. Number one is sometimes, you look at the MRI, and the problem I have with some of these is that the extent of the osteo is pretty significant on the MR pre-op. So if you get in there, you do a partial calcanectomy or a subtotal calcanectomy, and you have questionable, sinister appearing bone in there, what I'll augment it with is I'll cure it out, a lot of that remaining calcaneus, and fill it with antibiotic-loaded absorbable calcium sulfate beads. So I agree with John, when you use absorbable beads external to the bone, you get a lot of drainage. Well, you could get it with polymethyl methacrylate too, and the wounds get macerated, they start growing yeast and pseudomonas and dehiscence and all that. But I'll pack it in the calcaneus. If you look at elution properties for absorbable beads, they're superior to antibiotic elution properties of polymethyl methacrylate. You get much higher levels, and it is osteoconductive. So if I leave a deficit in that calcaneus, the residual calcaneus, I will pack it with absorbable antibiotic beads. The second thing is, if you're doing less than a radical calcanectomy, if you have a more focal area of osteomyelitis and you're having trouble closing it, in addition to debulking those flaps, what I find you could pick up a centimeter on each side with is beveling the sides. So instead of just rounding it off like John was showing you, another trick, he just didn't have the time to show you, is I'll take that medial and lateral wall and bevel it. And you'd be surprised how you could pick up a centimeter on each side, and sometimes it makes a difference between closing them or not. So I was asked to fill in at the last minute, and oh, one other thing. Sometimes these wounds are on the medial or lateral side of the heel. They're not always plantar. And when you excise those wounds, medial and lateral, and I don't have time to show you because I actually have a bunch of cases I could have showed you, but John was going to cover it. But sometimes these calcaneal osteos have medial or lateral wounds. And when you excise them, you have one side of the wound that's very concave and the other is convex, and it's difficult to close them because there's a tremendous difference in length on each side of that ulcer you excised. So if you have a tremendous discrepancy in the size of the wound after you excise a medial or lateral ulcer and you've done your calcanectomy and there's a mismatch, swing it to the plantar surface, measure the difference, and I'll take a wedge of tissue right out of the plantar all the way across down to the fascia to equalize the longer side versus the shorter side so that you convert it to a more linear incision. So I didn't know Dr. Gitlin. They were just asked me to fill in, and I wanted something relevant to this, so I thought I'd talk about can I treat osteomyelitis with oral antibiotics. So here's what I'm going to tell you. The truth is there's similar rates of cure whether you use IV or oral antibiotics for the treatment of osteomyelitis. IV antibiotics are not perfect. Your cure rate is not 100%. If you look at the literature, it ranges from 65 to 90%. With the antibiotics available today, it supports the use of oral antibiotics for treatment of osteomyelitis. And what you need is an immunocompetent patient and a patient who's cooperative. If you think about it, there has been no FDA-approved antibiotics for osteomyelitis in the last 15 years. You have very few guidelines. Osteomyelitis, as you probably all know, have a high rate of reoccurrence and is frequently limb-threatening. So this thing can be difficult to treat. As much as we treat osteomyelitis, there's a scarcity of literature to really give us firm directions. And even traditional antibiotics we'll talk about is not well supported. So these are the obvious advantages of oral antibiotics. I have 2 patients in-house right now before I left, and both really should have parenteral antibiotics, but infectious disease has conceded to treat them orally. We'll have to watch them closely. You don't have the PICC line problems. It's obviously more convenient. It's cheaper to treat with orals than parenteral antibiotics. These are the disadvantages, and obviously if you give orals, you have less predictable concentration of the antibiotics in the osteomyelitic bone, and compliance is clearly an issue. When you have them on home parenteral therapy, compliance is generally good. When you trust patients to take 1 or 2 or sometimes even 3 pills, if something like metronidazole is thrown in there, its studies have shown that on average, and you may or may not know this, on average, when you write a prescription for oral antibiotics, on average, patients take about 60 to 70% of those antibiotics. They hardly ever take 100%. So how do I make that decision about oral versus parenteral? Well, if it's cancellous bone, you have a better chance of oral antibiotics working because it's more vascularized bone. And if it's an acute osteomyelitis, you have a better chance of orals working because the bone is hyperemic from inflammation. So orals tend to work more poorly in cortical bone, and they tend to work more poorly in chronic osteomyelitis because obviously you have scarring in the bone itself. So we have our standards, of course, debridement and antibiotics for the treatment of osteomyelitis. And again, we do some limited surgery. We want to get down to healthy perfused bone because we want to have bone that's well vascularized, is not scarred up, so that we know whether it's parenteral or oral antibiotics, the antibiotics can penetrate that bone. And, as far as infectious disease goes, I don't know about Georgetown, but in St. Louis, the ID people I work with, they say, you tend to think, oh, I got all the infected bone out. So we'll say, well, how do you know? Oh, it looked healthy and it was hard. And then ID will look at you and say, so you could see germs. So the presumption is that there's still infection in the bone, even though we think we got out all the necrotic or sinister appearing bone. And that's one of the reasons that antibiotics are given following bone resection, because it's assumed that it's a bone that is infected, not part of a bone. You always want to get clean margin cultures. And when I speak to residents, and I always listen to John and learn from John, I always use a phrase that I heard him relate at one meeting some years ago. And he said, after you cut out the infected bone, he said, that infection's now in the laboratory. And what you're treating is what's left. So that clean margin culture is critical, because you've cut out part of that bone. So unless you're going to give the antibiotics to the piece of bone you sent to the laboratory, what's important is what's left. So you have to always get clean margins, and it makes a big difference. So we have different classification systems. When I was a student many years ago, we were taught the Wald-Vogel classification system for osteomyelitis, basically hematogenous, chronic, or direct spread, which is probably contiguous osteomyelitis, which is most commonly what we see. I like the Sierney-Mader classification system, and I think in podiatry, generally, it's true to say we generally treat type 2 or 3. We either have an ulceration with superficial osteomyelitis contaminating the outside of the bone, for example, an ulcer under a second metatarsal head. Someone, I don't remember if it was John or Dr. Friedman, somebody showed, I think it was John, showed a sub 1 osteo, and he cut out the ulcer, and the med head didn't look that bad. It didn't look all destroyed or chewed up or anything like that, because it was probably a Sierney-Mader 2 or 3. So either the outside of the bone was infected, or we have localized infection inside the bone. So that in many times, one advantage podiatry has over, say, orthopedics, we can literally cut out the osteo in many patients. We could get a pre-op MRI and say, okay, if we take out the distal 50% of this metatarsal or the proximal 50% of that calcaneus, we can literally cut out all the bone that looks abnormal on that MRI. You can't do that with a vertebral body. You can't do that with a femur. So we have a lot of advantages in podiatry. If you amputate an osteomyelitic toe and there's nothing proximal to that, you've basically cured the patient by removing the osteomyelitis. And one of the things I've learned, and like anyone who works with residents, we try to impart our experience to them, because we were residents at one time learning too, although we didn't always listen until we realized it was too late. I was telling somebody yesterday, I always tell the residents, when you're working with an attending and you're doing surgery, and the attending always goes, now right here, be careful. That means something god-awful happened to them in the past at that part of the surgery. And so you try to share your experience with them. I always tell them, over-resect. Once you take out the first med head, that MedHead's no longer weight-bearing. So what difference does it matter at that point if you take out 50% of the first MedHead versus 25%? The MedHead's done weight-bearing, so you're better off erroring to take out more bone once you've destroyed the weight bearing. All you're going to do by saying, well, I'm going to preserve the length of that first met, the only thing you're doing is possibly leaving behind some contaminated bone. So we have these different classification systems, but oral antibiotics works best for acute infections. Now, this is the traditional standard of care that we were all raised with. Those standards, believe it or not, if you search it out, go back to 1970. Just think about that. When your ID people tell you, oh, osteomyelitis, that's 4 to 6 weeks of parenteral antibiotics at a bactericidal level, that is a 50-year-old standard that until recently really has not been challenged, and there's no study that shows 100% cure rate. If you look at the guidelines of the Infectious Disease of Society of America, they have no specific recommended guidelines for the treatment of osteomyelitis. They do have guidelines, for example, for the treatment of MRSA. And even if you look at the treatment of MRSA, and these are available to you for free online. So unlike orthopedic surgeons and unlike podiatrists in medicine, they generally will allow you access to their journals at no charge. But people that do bone surgery, for some reason, want to always charge you, $55 to download the article. But real doctors in medicine don't do that. So the IDSA guidelines are available to you all at no charge. Just punch them up. And if you look up the guidelines for MRSA, they are very, very clear that while parenteral antibiotics are associated with better compliance, the fact is there's no data to show there's an advantage in the average patient, assuming you're looking at their cultures and sensitivity, not giving them something they're not sensitive to at a reasonable level there's no advantage to parenteral antibiotics. This is the guidelines of the IDSA for diabetic foot infections. And here again, you can see there's a lack of evidence for superiority of any one route of giving antibiotics. So here again, the old 50-year-old guideline that you have to give parenteral antibiotics is something that's been passed on for years and years and years. But in fact, if you look at the way in which that number was established, we don't know, for example, that 6 weeks of parenterals is actually ideal. We don't know if 8 weeks is better or 3 weeks is enough. We really have no data on that. So that's something that was passed on. This was a classic work by Spellberg and Lipsky looking at diabetic foot infections. And here again, their article clearly showed that the data does not support superiority of parenteral antibiotics. And as long as you're using an oral antibiotic to which that antibiotic that germ has a reasonable sensitivity, you are certainly within that broad standard of care to give oral antibiotics. And yes, there's no question that surgery increases the cure rate. This was, I think, a very classic study that was published in 2014. I mentioned it earlier today, and this was looking at antibiotics versus conservative surgery for treating diabetic foot infections. These are the organisms that you could imagine the majority were gram-positive cocci because that's typically what we see the most. And these were all forefoot ulcerations that they looked at, and they assigned patients to either surgery or antibiotics alone. The only surgery that was basically done was a biopsy of the bone and culture to confirm the organism. And this is the data I made reference to earlier. Doing antibiotic therapy alone for forefoot osteomyelitis in the diabetic patients, 75% of the patients had complete healing at about 7 weeks. And they had a just under 10% re-ulceration rate. And that's obviously because these are physicians doing this, not podiatrists. And so probably you have to think in terms of failure to control weight-bearing biomechanical factors. If you look at the patients that had surgical excision of the infected bone in the forefoot, they had about a 10% greater complete healing rate, shorter time, about 1 week shorter, but look at the re-ulceration rate, 1 out of 5. And again, we know why, because we've removed part of the weight-bearing surface. This is the Cochrane database. I don't know about you, but I tend to go to Cochrane database a lot to look for summaries of papers, just like organizations like the International Working Group on the Diabetic Foot. And there were 8 trials that met their qualifications for review. And the bottom line is there's no evidence to suggest that parenteral antibiotics for the treatment of osteomyelitis is in fact superior to oral antibiotics. I'm going to skip over that. There was a larger study that was just completed 2 years ago, and I just literally loaded this lecture up 20 minutes ago. And I apologize because I have an updated lecture because there was a large study that was just published, the OVID study, oral versus IV, and OVID study versus IV antibiotics for the treatment. And it was a huge study, just completed, just published, and it shows the same thing. So I apologize for not having that. I was hoping I had it on my thumb drive, but I didn't. Looking at oral antibiotics you could utilize for the treatment of osteomyelitis, I've listed the most common ones here. The thing I'm careful of, and you had a speaker earlier that mentioned, for example, ciprofloxacin and levaquin. Quinolone antibiotics, you've got to be careful. If you're not familiar with this, you've got lawyers that are advertising like crazy to sue for side effects from quinolone antibiotics. Quinolone antibiotics are not benign, and some of our colleagues use these in a very cavalier manner. Now, first of all, quinolone antibiotics are associated with a not insignificant rate of QT interval dysrhythmias and fatal arrhythmias. So that if you have a patient who's being treated for any kind of cardiac arrhythmia, you've got to think twice before putting them on a quinolone antibiotic. And we know we've got a lot of patients out there with atrial fib, for example, very, very common, and prolongation of the QT interval is very, very common. We've come to learn that quinolone antibiotics not infrequently cause a neuropathy, which is irreversible. They can cause a psychosis, they can cause depression, and they could cause myalgias. They could exacerbate Parkinson's disease if you're treating a patient that has Parkinson's disease. And we've come to learn that drugs like ciprofloxacin and levaquin are hardly benign. So if you have an alternative choice for treating osteo orally and you could avoid using a quinolone antibiotic, you're probably safer doing so. They have a term for this now called quinolone-associated disability syndrome. And you've now got black box warnings on quinolone antibiotics. So don't use them, whether it's soft tissue or in this case, osteomyelitis, in a cavalier manner. You also have a matter of convenience. Linezolid versus tadalafil, for example, doxycycline, a very, very common one used, and we'll go over a couple of these very, very quickly. Could you get that clicker reset for me? Sometimes it just sticks and doesn't work. Thank you. There we go. So let me go back to ciprofloxacin for a second. Again, standard dosage. It's got good bone concentration. It's approved for treatment of Pseudomonas osteomyelitis. In the right patient, you can use it for other gram-negatives, and certainly under certain circumstances, you could use it for gram-positive or Staphylococcus if they're sensitive. If you have hardware, for example, you've done Charcot joint reconstruction or you have some retained hardware, it just happened to me. I have a patient I just discharged that we had done beams on medial lateral for a Charcot, and the guy, I'm going to say 6 months later, developed an abscess posteriorly over the heel. We went in there, we debrided it down, and I could see the end of the beam that was going from the calcaneus into the cuboid in the fourth met. When you have retained hardware, if you're going to use any of these antibiotics for treating osteo, you're going to also include rifampin in your treatment. It lowers the rate of chronicity and recurrence of the infection. But I'm going to concentrate on no hardware. But some of these patients, those of you that do Charcot joint recons know, unfortunately, some of them come back or have a mixed picture. And when hardware is involved, and you don't want to, I didn't want to pull the beams, they weren't loose. There was no lucency on the x-rays to suggest they were involved in the infection. But as we debrided down that calcaneus last week, I could see the end of one of the beams, and the infection sort of went up to that level. So there's good studies using ciprofloxacin for treatment of osteomyelitis. But again, you got to watch that as far as tendon rupture goes. That was the first thing that was described. We were all looking for Achilles tendon ruptures. It's not unique to just the Achilles tendon. Any tendon can rupture with ciprofloxacin. So that was the first bad PR that it got. The latest is that ciprofloxacin and quinolones are associated with aortic aneurysms. rupture. So again, this is certainly not a complication that we want to get involved in. So as a podiatrist, if you're going to use a quinolone antibiotic, step back for a section, for a minute, make sure they don't have a dysrhythmia, that they could get a fatal arrhythmia from this, so be very, very careful. Trimethoprim sulfamethoxazole has excellent data for its use for oral treatment of osteomyelitis. That's, Bactrim, Septra. Make sure they're not allergic to sulfa-containing medications, and you do want to watch their BUN and creatinines. And one of the habits I've learned to get into now is when I'm doing antibiotic therapy on patients, and someone asked a question earlier about labs. I'm very big on getting labs, so I'm not sure I agree that you don't want to get baseline labs because you never know when somebody's a little bit sicker than you think they are. So I do like to get baseline CBCs, CRPs, and ESRs. I use procalcitonin in certain situations, particularly with a Charcot or neuropathic bone disease versus osteomyelitis. I've been looking at procalcitonins for a while now. I think it's an underutilized test. It's available in the community now. Originally, it was just available for, they were using it in ICUs for pneumonia spreading in ICUs and things like that. Procalcitonin will be elevated within hours of the onset of an infection. And what's nice about a procalcitonin is if you have the patient on the right antibiotic, it'll drop down immediately so that you can immediately see your surgical debridement was probably satisfactory. You probably have them on the right antibiotic. If you have a persistence of procalcitonin, then you have to wonder whether or not there's more abscess than you thought, maybe more bone infection than you thought, or maybe they're not on an antibiotic that's effective for whatever reason. So it's kind of like looking at a C-reactive protein versus a SED rate. You all know a CRP is going to drop down sooner. So if a patient's had surgery, for example, and you're treating them for an infection, you all know that post-op, your inflammatory markers are going to be elevated and you're hoping to see them drop down. And if you look at the order in which they drop down, procalcitonin will decrease first, then your C-reactive protein, and then lastly, your sedimentation rate. So I do use a lot of trimethoprim sulfamethoxazole, 100 milligram BID. It's very, very helpful for that. You do have to watch their CBCs and make sure they're not getting leukopenic or thrombocytopenic or getting anemic because a generalized decrease in blood count can occur. Linezolid can be utilized for the treatment of osteomyelitis, standard dosage, 600 milligrams BID. The disadvantage of linezolid is you got to monitor them carefully for thrombocytopenia, for anemia. Once again, with linezolid, you can get an irreversible neuropathy. And if they are on an MAO inhibitor, they can get a serotonin syndrome. Tidizolid, the advantage of tidizolid over linezolid is you don't get the neuropathy, you don't get the thrombocytopenia, and serotonin syndrome is not an issue. So if the patient's being treated, for example, for some psychiatric problem and you're on an MAO inhibitor, then you're safer using tidizolid than you are linezolid, but you certainly can utilize that. Clindamycin was discussed earlier. Make sure that the patient is sensitive. Make sure they're not resistant to erythromycin. Good data for using clindamycin for the treatment orally of osteomyelitis. Obviously, you're talking about gram-positives and some anaerobes, 450 milligrams 3 times a day or 300 milligrams 4 times a day. Good oral bioavailability, good bone penetration, and obviously you're going to make sure you're asking them about any diarrhea, abdominal pain, that kind of thing. So I'd mentioned tetracyclines before, and again, the one I most commonly use is doxycycline, 100 milligram BID. If you have an anaerobe, you have several choices. One's obviously amoxicillin clavulanic acid, but a GI upset's not rare. Metronidazole, 500 milligrams TID. So that's for the unusual but occasional case of anaerobic osteomyelitis that you get. There are many studies looking at oral antibiotics for the treatment of osteomyelitis, and I apologize for not having my most updated version, including that OVIV study, because that's the most recent and showed overwhelmingly that there's no advantage to parenteral antibiotics. And I know in the St. Louis area, our ID people have slowly been allowing more and more use of oral antibiotics, all things being equal. I mean, you got to have a cooperative patient, you got to have vascularized bone, you have to have an acute process rather than chronic, that type of thing. So number one, we don't have a clear definition from study to study of whether they were acute or chronic. Many of the studies, believe it or not, didn't tell you why they had osteo, whether it was a diabetic ulcer or a puncture wound or hematogenous from something. Many of the studies did not include bone biopsy. There was a presumptive diagnosis of osteomyelitis. The different studies had different follow-up times. Some of them were relatively small samples, and a lot of them had ill-defined endpoints or variable endpoints of when did you decide that they were cured of their osteomyelitis, because all of you know that osteomyelitis is a disease that's characterized at times by recurrences which can occur later. And I know when I started practice many years ago, we didn't have the antibiotics that we had now, and it was very common to see patients that had osteomyelitis, they got better, and then they would break open years later. And these were the patients that had those chronic wounds, and you heard all about rodent ulcers with squamous cell carcinomas developing and all that kind of thing. So when are oral antibiotics appropriate? Well, it's got to be an immunocompetent patient. It's got to be, or it doesn't have to be, but it's best acute osteomyelitis. When are they not appropriate? Well, to me, number one is noncompliance, because again, the studies have clearly shown that patients on average only take 60, at most 70% of the oral antibiotics that you prescribe. So you really got to make it clear to them that if they don't do this, they're risking their limb, they're risking amputation. Obviously, they have to have adequate GI tract function. And I mentioned autonomic neuropathy before. Well, your autonomic nerves are responsible for, as you know, GI motility. And sometimes these patients have diarrhea or constipation, GI tract motility problems. It's not good for gangrene, because if there's no blood supply, there's no antibiotics getting in there, obviously. And you can say the same thing about chronic osteomyelitis. Obviously, if they have chronic ischemia, the antibiotics are not going to penetrate. So there are situations where it's not important. So as I said at the very beginning, to summarize this, you have similar rates of cure of osteomyelitis, whether it's parenteral or whether it's oral. Even IV antibiotics do not have a 100% cure rate. Today's antibiotics have excellent pharmacokinetics, such as they are easily or acceptable for treatment of osteomyelitis. And you consider this oral therapy for 4 to 8 weeks, and make sure that you're getting clean cultures. Because, for example, if you remove all of the osteo, then you hardly need any antibiotics to follow, because you've removed, like John said years ago, and I thought it was a great line, the osteo is now in the laboratory. So you take your clean cultures, and if there's nothing there, you'll tend to give them a week, maybe to make yourself feel better. And then I do want to say again that for some of these cases, like in the calcaneus, if the inside of the bone is still involved and looks kind of mushy, think about absorbable beads. And by the way, I also pack them in, for example, medullary canals on, say, a ray resection, particularly a first ray, where you've curated out, the bone's soft, and you've sort of reached your end of resection. So I do like that combination, but in general, I've gone more to a short course of parenterals, prolonged course of orals, and the literature's there to support that choice. Okay? All right.